To today's program, Navigating Emergencies in a Pandemic, Emergency Room Not, is part of the educational program activity of Bikur Cholim of Greater Washington and a number of local synagogues. They're all listed in the announcement for this program. Before we get started, a word about logistics. We'll hear our speakers, Dr. Eva Moses and Dr. Neil Siegel and Rabbi Rosenbaum, and after the remarks, we'll have time for questions and answers. I'll moderate this process. Send me your questions through the chat feature. Please mute yourselves. Keeping this program and plan to make it available online. Now we know that it is a mitzvah to care for ourselves, our bodies, and it is also a mitzvah to care for the sick, for others. Part of that care is knowing when to get help, recognizing the signs, especially when immediate attention is required. Among other questions, our speakers will help us to plan for emergencies where we can be ready for what we can control. Because of COVID, emergency rooms have changed some of their procedures, which have changed who gets in and how to communicate once you are in the ER. What can get us to the ER will invariably require some follow-up. That will be the subject of our second speaker. As that can sometimes happen, we or a loved one may need to be in the ER or hospital over Shabbos or Yom Tov. So these are three major categories of discussions. I want to talk now just briefly about our main sponsor, Bikur Cholim of Greater Washington. If you and or loved one find yourself in the emergency room, Bikur Cholim of Greater Washington has you covered with emergency bags, Shabbat boxes at a number of local hospitals, and kosher pantries at a number of them. They are listed at Bikur Cholim of Greater Washington website, and I've placed that in the chat room to get us started. They're listed there, and you'll also find ways to support this important and worthwhile organization that is part of our community safety net. Now, just a quick rundown. Georgetown has one, George Washington has one in terms of emergency bags, Holy Cross, the one in Germantown as well, the one next door to us, Inova Alexandria Hospital, Inova in Fairfax, Montgomery General, Sibley, Memorial Hospital, Suburban Hospital, Washington Hospital Center. We also have more substantial pantries at Holy Cross, Chili Grove Adventist Hospital, and Children's National Medical Center. Our speakers, there are three of them. Dr. Eva Moses grew up in St. Louis, Missouri. She studied in Israel before attending the Massachusetts Institute of Technology, where she met and married her husband, Isaac. She received a Bachelor of Science there in biology, then moved briefly to Camp Mill before going to Baltimore to attend the University of Maryland School of Medicine, where she graduated in 2010. They then moved to St. Louis for residency in emergency medicine. And for the past 6.5 years, Eva and Isaac and family have been back in Camp Mill, with Eva serving as attending physician in emergency medicine at Holy Cross Hospital, both in Silver Spring and Germantown. And she and Isaac have 4 children, all in Camp Mill. Dr. Neil Siegel has lived in Silver Spring since 1989. He graduated from Brooklyn College and SUNY Downstate School of Medicine. He completed his residency and served as chief resident in family medicine in the Georgetown University Providence Hospital Family Medicine Program. For the past 26 years, he has practiced as a clinical assistant professor of family medicine at the University of Maryland School of Medicine in Baltimore. He's also the University of Maryland Medical System Medical Director of Ambulatory Clinical Informatics. He and his wife, Audrey Berman Siegel, have proudly raised their 6 children together in the communities of Camp Mill and Woodside. Finally, but not least, Rabbi David Rosenbaum of Young Israel Shomer Emunah has been with the shul for 15 years, the last 10 as a Mara De'atra. He fields many questions involving medical care under emergency and other circumstances, and he plays an extensive role in the Washington Jewish Orthodox community. He and his wife Atara and 4 children in Camp Mill. So I'll turn this over to our first speaker, and that would be Dr. Moses.
I unmuted you.
Okay. Oh, great. Thank you. And sorry, just one sec. Okay. All right. So hi, thank you, Max. As many people know, I'm a community member first and emergency physician second. I work at Holy Cross, as Max mentioned. So this is unfortunately probably the most important slide from some perspectives, but everything I say shouldn't be considered medical advice for specific situations, and everything I say in this presentation are my views alone, and don't represent those of my employer or any organization with which I'm affiliated. So just a few pictures of what it's like in the emergency department and what it probably feels like for people. Very overwhelming, usually something you can't plan out. And for that reason, it can be really helpful, I think, to think ahead of time about what will be required if you do need to go to the emergency department. In the moment, you could be very overwhelmed, very upset, and the moment could be really chaotic, and it's easy to forget what things you might need to bring with you. So the first thing I wanted to talk about is how to decide if you need to go to the emergency department, how you might get there if you do need to go. And a lot of people call the emergency department ahead of time and they'll ask for advice. And despite the fact that we do have phone lines, we're not the ones to call in this situation. You're not going to speak to an emergency, like a medical professional. It's just more of a clerical professional in that case. And there's also federal regulation called the Emergency Medical Treatment and Labor Act that makes it so that people are very careful about what we say to tell people whether or not they should come into the hospital. This is a federal law, and it requires that anyone coming to the emergency department be evaluated and screened for medical conditions and stabilized before, regardless of their insurance status or ability to pay. It can be interpreted very strictly, and so many hospital systems are extremely careful about how they talk to patients who are considering checking in. So if you walk in the front door and say, should I check in? It's really hard for us to say, nah, you probably don't need to. You probably should not ask us that question at that point. Where I work, they try not to even ask you for your insurance information or for a copay before you've been seen by a doctor or advanced practice practitioner, because they want to make sure it doesn't seem like we're implying that we want your money and then we'll see you. So other options is you could call on the back of many insurance cards or phone numbers that you can call, and frequently there's a nurse hotline. They can both help you decide whether or not you should go into the emergency department or what other kinds of care might be an option for you. And they can also help you decide how you should get there. Deciding, what sort of symptoms you're having and if you're safe to drive or ride in a car. An exception to all of this is that when you have recently had surgery, childbirth, or any other major medical procedure, it's almost a rule that you have to call your surgeon or doctor, because they really want to hear from you, and they probably have given you paperwork that has a list of things to watch out for. And from my own personal experience, I've left surgery centers or hospitals after procedures with myself or my children, and it's a very overwhelming time. It's hard to remember everything they said to you in that moment, but try to put that paperwork in a safe place so you can refer back to it if you start having any symptoms that worry you. If you're post-operation or post-procedure, again, just can't emphasize enough how much your specialists want to hear from you. And they might be able to tell you, I'll see you in the office first thing in the morning, and that could save you a visit to the hospital. Also, don't feel like you're saving them a call, because if you come into my emergency department, I will call them no matter what time of day it is, because if I don't, I'll be hearing from them in a different time. They want to know what's going on with you. So other situations to consider is that many times it's safe to go by private vehicle to the hospital. Uber drivers are becoming increasingly one of the ways that we see people getting to the hospital. Not that I'm necessarily saying that's the best way to go, but it's interesting at least. But sometimes an ambulance is the way to go, and if you're not sure, you should definitely probably call 911. The ambulance staff can help decide the best hospital for your situation, and they can also decide whether or not treatment is indicated, that they can even start immediately. In cases of injury, they're trained to move patients and get them out of tight spots, both literally and figuratively. and then, not worsen the injury that way. I also wanted to mention that many people think that if they take an ambulance, they can skip the line or skip the waiting room, but unfortunately, that's really not the case. Obviously, in cases of severe illness, we never want to keep anybody waiting, and we never want to keep anybody waiting if we can help it at all. But if a patient's stable and no rooms are available, or a room needs to go to a more acutely ill patient, then that patient may have to go from the ambulance right out to the waiting room. So it's upsetting sometimes, but good to know ahead of time. So as I mentioned before, there's a whole lot of options available for medical care, and it can be hard to decide where to go. And as mentioned before, there are some resources that can direct you. And for the most part, if you're dealing with long-standing chronic medical conditions, your primary care provider or your specialist can either see you or direct you to come into the emergency department. And definitely contacting them is a good way to go if you're not sure if you need to go in. Different offices, have different availability for how quickly they can see patients, and that's something we are aware of. But, it's at least important to contact them. Urgent care is a really great option for minor illnesses or injury, and frequently they will refer to the ER if it seems to be beyond their capabilities. Possibilities of what might be on their capabilities include surgery, imaging that's more advanced than x-rays. They usually are not very comfortable with chest pain or any complaint requiring cardiac monitoring. And they're not governed in most cases by the same laws that require a medical screening before payment. So frequently the emergency department ends up being sort of this safety net or catch-all when the rest of the system is difficult to navigate. Many emergency departments actually have subset areas like an urgent care or fast track area that are for more simple problems like sprains or minor broken bones, stitches. They might have that name like express care, rapid assessment. In those cases, you're still getting care in the emergency department under the auspices of an emergency physician, and you've been triaged to that area because it's been seen as appropriate by the triage nurse. If it turns out that your needs change, or it turns out that a more severe illness is actually present than what was originally thought, sometimes you get moved to a different area of the ER, or sometimes the appropriate care is provided to you in the area that you're in. There's one other kind of emergency care that people might not be as familiar with, which is a freestanding emergency department. And that's sort of, it's really an emergency department, but in the fact that it's not connected to a full hospital physically, it's sort of like an urgent care. They're generally the sort of places where you can get a full workup just like you would in an emergency department. They are usually staffed by emergency physicians, and they tend to be affiliated with hospitals or hospital systems. And then when patients will require admission or more specialized care, they usually have a streamlined process within their system and can directly admit you from their building over to the main hospital. Ambulances can go there, and they're also governed by the EMTALA law, but they try in general not to take patients there that they feel will need admission, and there's a few of those in the area. So just to talk a little bit about how emergency medicine is different from other specialties. I frequently have patients, especially older ones, ask me what my eventual specialty will be. And this is because in the past, like when my father was training, many physicians would spend time in the emergency department before moving on to other fields. But around the time that my father was training in medicine, it was also recognized that emergency medicine is really a specialty in its own right and requires specialized training. We are trained to think of the worst diagnosis first and rule out all the diagnoses that you can't miss. Basically, we're also uniquely qualified to handle the initial stages of emergencies in a whole variety of fields. So these include orthopedic, surgical, medical, pediatric, OBGYN. We're sort of like, we have the shallow lake view of all the emergencies, but we don't go as deep into the individual specialties. There are many symptoms within all of those that patients should never ignore, and obviously this list is not exhaustive or exclusive, but They include chest pain, shortness of breath, any uncontrolled or continued bleeding from various sources, abdominal pain, especially that which is new, severe, consistent, associated with fever or nausea or vomiting. Patients who are lethargic or seem very out of it are always at risk for severe illness, and new onset weakness, numbness, feeling unsteady or dizzy can be signs of a stroke. The earlier that you present with those symptoms, the more treatment options are generally available for those patients. And any headache that's new and severe or sudden or different from a regular headache, it definitely warrants at least discussion and possibly evaluation. So to talk about the big elephant in the room, COVID-19 and the emergency department, it's definitely been an interesting ride. So emergency medicine has been on the front lines of this pandemic, and it's been a uniquely challenging situation for many, many reasons. This is a new disease and we're still learning about it every day. In March and April, our patient volumes dropped dramatically, and this was really the case across the country. Some of this was expected because we do see a lot of people who could seek care other ways or may not be having real emergencies, and fear cut down on those visits. We also, see a lot of kids with fever and cold, but if you're not going to school, those aren't getting passed around quite as much. But in other ways, we were really concerned, and that's one of the good points of having this presentation, because we wouldn't really expect to see appendicitis, heart attack, stroke really significantly decrease during the lockdown, but we did see patients coming in with those symptoms dramatically decrease, just like all the others. And it was really surprising that we were that effective with our messaging, telling people that they should stay home. So then the COVID-19 patients did start coming in, and we adjusted to caring for those patients, and they were quite ill. But we got used to it and we learned a lot. So now our regular volume is back up. We're not quite at pre-pandemic numbers, but we're close, and the COVID numbers are down, and we're sort of back to business as normal. I wanted to talk a little bit about how we are keeping you safe in the hospital and why you shouldn't push off your appendicitis or your heart attack or stroke, and why you should come in anyway. So most hospital workers have been spending 12-hour shifts or longer in the hospital, and they haven't contracted the virus. We have designated areas that we direct patients to if they have fever or have other reasons to be under investigation for coronavirus. Most of these areas have doors that close or negative pressure systems that actually vent the air from where they are in. They vent it away from public spaces. So mask wearing is required of everybody in the hospital, and the visitor policies are very strict. And while it seems harsh, some of that is to cut down on the sheer volume of patients walking through, because we do know there is possible asymptomatic spread and exposure. Medicine has changed in other ways. So a lot of primary providers or specialists have switched to telemedicine, and some of that's all exclusively, and some of them are doing that partially. And this can be challenging for a lot of people. It can be hard to navigate these systems. Certain complaints are hard to evaluate over phone or internet. And I've heard from some patients that they feel like they aren't getting the same level of care, but still getting charged. And obviously that's a big concern for many people. So we do sometimes see people come in either directed by their primary providers to the ER because they can't see them in person, or just patients feel like they need to see a doctor in person. A lot of people also in these times have a lot of questions about exposures, what constitutes a need to quarantine. And I really wanted to, with my platform, put in a plug for contacting the health department if you have these questions, because each situation is unique, and there can be nuances that are tricky to sort out. And sometimes we can be over stringent on ourselves. If somebody asks me, should I quarantine? It can be safest for me to say, yeah, you probably should. But if you ask the health department, they might be easier on you. I can tell you what to do when you're sick with coronavirus, but some of the other situations really aren't my area of expertise. I also wanted to stress that if you are curious that you might have coronavirus or not having significant symptoms, the emergency department is not the place to go. And the way we think about decisions in medicine is frequently a risk-benefit analysis and calculation. So does the risk of what I'm going to do outweigh the benefit? If that's the case, you probably shouldn't do it. If the benefit outweighs the risk, then we should probably go ahead and do whatever we're considering. So if you're having trouble breathing with a fever, cough, or any other of the big concerns, or just even feel sick enough that you feel you need medical evaluation, by all means, come into the emergency department. The risk that you will run is definitely outweighed by the benefit of getting that medical evaluation and advice. But if you're really feeling okay and you just think you probably have coronavirus, but it's really not severe, it's probably better not to come into the ER, because you're probably taking more risk in the fact that you might not have it and you could get it. Testing is available other places, and you can definitely, there's tons of information available online about how to get that testing. I know for a while the Montgomery County testing was out of commission, but I'm pretty sure it's back up. So just a little bit more about thinking about the emergency visit that you might eventually have in advance. So if you have an advance directive or any power of attorney paperwork, all that information is really good to have in one place so you can grab it on the way out the door. For most of us, it's wise to prepare paperwork even if we don't have an advance directive, but paperwork that has a list of our medications, surgeries, allergies, major procedures, and at least some emergency contacts, even if you don't have an advance directive, because if you're unconscious, which is rare but does happen, we need to know who to reach out to and inform if we need to make some information available. So other things that are really good to keep in mind, that if you're going to the ER and might be there for a while, if you take any rare or expensive medications and substitutions are not an option for you, for whatever reason, allergies, or they're not effective, then bring those actual medications in with you, because sometimes the hospital does not have those on formulary. And if it's time sensitive, then it can be really helpful to have it with you, and that your doctor can approve you to take that medication while you're in the ER, because some people do have those specific requirements. It's great to have that updated list of medications, but sometimes people don't remember to update it, and that's pretty common because changes can be made pretty frequently. So one thing that a lot of people do, which is terrific, we have no problem with that, is just bring in your whole big bag of medications. We're really quick and easy at just looking through them, toss the ones that aren't interesting off to the side, and give you your bag back. If you end up bringing in your pill sorter, that works better than telling me that you take a little green pill, because at least we can actually Google what the pill is. But if you tell me a little green pill, there's a lot of little green pills and they can all look different. More things to prepare for your visit. Being aware of the visitor policies is important. During the coronavirus pandemic, most hospitals are currently having very strict visitor policies. This means that children under 18 get to have a family member at bedside, and you can usually push for someone in the ER for other patients as well, but you have to know how to do it. So examples of this include if a patient has dementia, but they're calm with family members, with familiar faces or caregivers. Somebody who has a baseline altered mental status, which would be confusing to staff. You can kind of argue that patient care will be disrupted if you don't have somebody with them who can explain things. And always how you ask and how you try to navigate the situation makes a huge difference. So if you really want a visitor, you catch more flies with honey. So a smile, a kindness to the staff who are busy and overworked, and mentioning this patient really, requires help for even minimal changes, and I'm happy to do that. I'm not trying to say that emergency staff are not willing to help patients, but we're busy. And so if somebody's going to require constant attendance, mentioning that and letting them know that you want to be there to do that for them will make a big difference. Don't forget your book. You're going to be there a while. You may not have that TV. If it's Shabbos, you probably won't watch that TV. Don't forget your cell phone charger. A lot of people ask for cell phone chargers, and a lot of medical staff have lost their cell phone chargers by lending them to patients. So you may, it's just hit or miss whether one of us has your same kind of cell phone and is willing to share. We've had patients with special dietary concerns, such as people with celiac disease who had a hypoglycemic episode, and one of the best ways to treat hypoglycemia once we get them conscious is to feed them. but if they can't eat most of the food we have. So if that's an issue for you, especially you're somebody with dietary concerns and diabetes, keep a snack on hand that you can eat. So next, just talking a little bit about communication in the emergency departments. It's a pretty chaotic environment, and most of the interaction you're going to be having is with your nurse. They're a very powerful person, and remember that when you're making friends. Take the time that you're waiting to spend talking to your doctor and write down a list of what you want to tell them and questions you have. They're going to come back and talk to you again, but it may not be for a while. And the way we usually do kind of our workflow is we see a patient, we make a full list of all the tests we're going to do, and then we come back to them when those tests are done and talk about the plan. What can happen is if you remember after all those tests are done that you also had another concern, then we might have to restart the whole test process again, and that just takes up a lot of time. Also tell doctors and nurses up front about family members you want to authorize to hear about what's going on with your condition. When we are talking to you as a patient, we don't generally need signed paperwork about that, but we'll document that in the chart. They want their son to be aware and, you know, write down his name or whatever it is. And that way we can, you know, confirm that it's okay for us to share when family members during these no visitor times inevitably call. Wanted to talk a little bit about how to best handle the flow of information during our no visitor policy times. So it's best if the patient is awake and alert and fully aware of what's going on. We try to just mostly interface with them and tell them what's going on. And then hopefully they can talk to their family members. It's the best way for patients to be empowered and us not to feel as though we're sort of going around the patient. Obviously, in some cases, that's not entirely possible. And in some cases, it may not be 100% clear to the patient or to the family members once they've played a game of telephone, hearing about what's going on. And so in that case, we're always happy to talk to somebody who's been authorized by the patient to hear about the medical condition. The ER is a very busy place and the phone is usually ringing off the hook. And everybody is under different strains now that we don't have visitors. So what I recommend is pick the best family member who is maybe the most medically knowledgeable to be the communicator, and they can be the ones to call the ER and get updates. And that way we don't have somebody calling 5 minutes later wanting the exact same update, because, you know, workflow interruptions, and we have probably at least 10 other patients we're thinking about at that same moment. I've actually had people say, well, I don't talk to my sister. And then we say, well, I'm sorry, now's the time to bury that hatchet. So if we do need to speak to your doctor, we'll reach out to them. Depending on the time of day and depending on the office, sometimes it's easier than other times to reach out to them and to get a hold of them. We don't generally have a system set up where we fax any information to your doctor. So most of us will print all of your results for you. And if we forget to do that, please remind us. And that way, if you bring that with all your discharge paperwork and get that information to your doctor, they can usually understand kind of what we were looking at and what our thought process was. Just to touch a little bit on children in the emergency department, general emergency medicine physicians are trained to deal with pediatric emergencies as well. There are also specialized pediatric emergency physicians who have completed a residency in pediatrics, and then they do further training in pediatric emergency medicine, a fellowship. They have a slightly different training and focus, but overall we pretty much approach the emergencies in a similar manner. For the most part, children are healthier than adults, but they get more frequent fevers and other illnesses and have just as many worried parents as adults. Sometimes more. They can sometimes look sick when their fever's high, and at other times they can be running around having a high fever, something that would knock you or me out. They also come in frequently for falls, broken bones, head injuries, cuts, and we work really hard to try to keep the child calm and make it a calm and unthreatening environment for children. And the parents can really help with that by remaining calm themselves and trying to stay positive, because kids can really sense their parents' stress and anxiety. Pediatricians and family doctors are great people to contact if you aren't sure if you should take your child in for evaluation. They usually have very active and robust answering services, and they can direct you as to when you should seek emergency care. And I can't say enough how important this is for newborns or patients who are in the first few years of life, first few months of life, sorry, because at that stage, the illnesses can be quite severe and it might not be immediately obvious. So don't hesitate to reach out to them. We do have a lot of familiarity with end of life situations, and it's really smart to be prepared if you have a patient, for people who are critically or terminally ill. And for those with advanced directives, if they do end up getting transported to the hospital by ambulance, inform the EMS providers of their paperwork and make sure they have a copy, because if patients have decided that CPR or breathing support isn't going to be in their care plan, we need to know that. If we have no paperwork or don't have any sort of way to find out and we have to take immediate action, we have to assume the opposite, and we have to assume that we are going to go ahead and provide all care. One exception to our visitor policies during COVID is the end of life, and it's still fairly restricted, but we do try to allow family members to be present to some extent. I think there are limitations on time and how many can be present. So talking about what to do after the emergency department, and this sort of streamlines a little into Dr. Siegel's presentation, but if all goes well and you're discharged, there are several possibilities. So you may have presented with pain or some vague symptoms, and we went through a big workup to rule out emergency conditions. We may not have a definitive diagnosis at the end of that. It's possible that we may not know what's happening. And sometimes I like to describe it as we can tell you what it isn't, but we can't tell you what it is. If we're discharging you, we think you're safe to follow up, but often we don't know the cause of your symptoms. And that's frustrating because uncertainty is always frustrating. We usually give patients a list of symptoms to watch out for. And it's important to remember that no test is perfect. So even if we did a test for a certain disease, we still want you to watch out, and if things progress in a certain manner, it's important to get reevaluated. The hospital has a list of on-call providers in different specialties who have committed to come into the hospital for emergencies. And they're generally people that we know well, and we have a long-standing relationship with them. They're also available to follow up with people. And the idea is the week that they're on call, they sort of know that they're on call. They're not going to be going out of town, or they're hopefully going to be keeping some appointments available for people who were in the emergency department. If you have a prior relationship with a specialist, obviously following up with them is usually a good move, but sometimes, they may be on their vacation. And I think Dr. Siegel is going to talk about this as well, but when you're scheduling follow-up appointments, it's always advantageous to mention your recent ER visit, and because frequently they save some appointments for emergencies like that. And so just my sources, and that's mostly what I have. And I will stop my sharing.
Okay, Max, do you want me to pick up from here?
Yes. Eva, you done?
Yep.
Yep. Thank you very much.
That's me.
Dr. Siegel, please start. Thank you very much, Dr. Moses. Okay, to you, Neil.
Thank you. I'm about to try to share my screen. Please let me know when you're seeing that, somebody.
Okay.
Okay, you're seeing my screen now?
Yep, thank you.
Okay, thank you. Thank you, everyone. Thank you, Max, for asking me to participate in this program this morning. Rabbi Rosenbaum, of course, and thank you, Dr. Moses, for that very, very worthwhile and helpful, informative talk. Might be asking, why am I, a primary care doctor, talking about the emergency room? And I think Dr. Moses sort of gave me a nice lead-in about that. As we designed this talk that was primarily about the emergency room, we thought it would also be important to discuss what happens before and after an ER visit. Now, Dr. Moses has already discussed some of the planning you can do before, so I'm just going to take a few minutes this morning to focus on what happens after leaving. And first, just a brief disclosure or disclaimer similar to what Dr. Moses mentioned, that these are my own opinions. It's not medical advice. It does not represent any of the organizations with which I'm affiliated. I also just want to mention, it occurred to me as I heard Dr. Moses' presentation, for all the segments where we're speaking about COVID and some of the current rules, I want to emphasize that it is just that. These are the current rules. Unfortunately, it is still a very new condition. Baruch Hashem, right now in Maryland, we seem to be in a slightly better phase, but nobody knows what the next few months will bring. Sometimes it feels like we don't know what the next few days will bring. So any advice that we give about COVID, particular visitor policies, office precautions, please keep in mind that that's for the current situation. So I'm gonna go to my next slide, I hope. Okay, so in talking about primary care, I thought it might help that we're all on the same page, and a definition of primary care and primary care providers that I found online I thought was helpful. Starts with what you see on the slide here. Primary care is a range of health services that cover a range of prevention, wellness, and treatment for common illnesses. Primary care providers include doctors, nurses, and physician assistants, nurse practitioners, and physician assistants. And primary care specialties usually include pediatrics, adult internal medicine, and family medicine. Continuing this online definition, primary care providers often maintain long-term relationships with you and advise and treat you on a range of health-related issues. They may also coordinate your care with other specialists. So that's the end of the official quote. And I stole this photo from Dr. Moses' slideshow, Truth in Advertising. To emphasize a point I like to frequently emphasize with my medical students. You know, at University of Maryland, we have the world famous Shock Trauma Center, and doctors from all over the world come to shock trauma to get training specifically in emergencies. Emergency and particularly trauma care, we talk about the golden hour, and these are the first 60 minutes that can be critical in saving lives and preventing illness. That's very glamorous. Also, over the last few decades, medical shows television shows, movies have tended to be more about the emergency room and the glamour of immediate responses. And what I like to emphasize with those students, and I'd like to emphasize with you, is that primary care, we save people's lives and we enhance lives over the spectrum, Emir Hashem, to 120, in all ages and all stages of life. It's that longitudinal care that we specialize in. And we hope that that helps people of all ages and health conditions to lead a longer, happier, and healthier life. So as you heard Dr. Moses describe it, one of the very important functions of the emergency room is to determine the severity of a patient's conditions. Oftentimes, the emergency room doctors will be completely evaluating and treating your concern, but at other times, they're really serving this function to decide, is this problem so severe that the patient needs to stay in the hospital, or can we in the emergency room start the evaluation of treatment, then send the patient home to continue care with their usual physicians. And so some problems identified at the ER will be fully diagnosed and treated by the time of discharge, but many more will require continued care. And you can see here I've outlined a couple of those examples. So primary care providers, what will we do after you've been to the emergency room? Primary care physicians may complete the care of an acute concern. Maybe you went with a muscle strain or a rash that isn't going to clear up just in the few hours that you're there. Or we may be helping you to control any chronic conditions, such as asthma or diabetes, that may have flared up and led to that emergency visit. In both of these situations, whether it's acute or chronic, timely follow-up with a primary care physician is important to achieve your best healing, prevent worsening or recurrence of the condition. And a word about children as well, just as Dr. Moses pointed out, it is true that more children's conditions treated at the ER are likely to fully resolve without further follow-up. Some of these might have even been prevented. We might have saved you a trip to the emergency room by some of the things that she mentioned about calling your doctor ahead of time, calling the doctor on call. By the way, I happen to be the doctor on call for my practice today. So a person calling right now might be delayed 10 minutes in my response. But we have doctors on call, nice weekends, 24/7, for just such situations. And as Dr. Moses mentioned, that doctor knows that they may be fielding questions about whether to go to the emergency room or not. But again, for children, after they've been to the emergency room, your pediatrician or family doctor will want to be contacted after the fact. They want to be aware of all your child's health concerns. We want to have a complete understanding of the children's health. And also sometimes that ongoing care, that longitudinal care, as a primary doctor, we may put together things that one ER visit wouldn't necessarily have noticed. If your child is going to the emergency room every year in April for severe congestion, it may turn out that we should be looking more at allergies. So by the way, the drawing on the left is a reminder, and Max mentioned that I'm our medical director for clinical informatics. I'll be talking more about how technology and electronic medical records may help. However, this is a famous drawing that was published a few years ago in the Journal of American Medical Association, JAMA. And this was drawing by a 7-year-old in her pediatrician's office. And this is the 7-year-old with her family members. And she thought the doctor's job was to sit with his back to her, typing at a computer. So I hope none of you have experienced that, but we want to clearly keep that in mind, that our job is to be facing this other direction and working with you as a patient. So how to get timely follow-up, and I think these next two slides really they're my last two slides, but they're the heart of why I'm speaking with us this morning. If urgent follow-up is needed, the emergency doctor or staff may call your doctor's office or the doctor on call, even if it's after hours. However, if you are supposed to call your doctor's office, be sure to tell the scheduler that you or your loved one were just in the emergency room. This is something that Dr. Moses just mentioned, and I strongly want to reiterate that. Unfortunately, sometimes, especially right now, as we are recovering our office schedules from COVID, sometimes there might be a month, even occasionally a 2-month wait for a routine appointment. However, most practices do keep aside urgent and emergent same-day slots or 1 to 2 day slots, particularly for people who've been to the emergency room. Okay. Now, we mentioned also that especially since the COVID pandemic emergency, telemedicine has really taken off in the United States. And I may have a somewhat different take on that experience from what Dr. Moses does, just from my practice and perspective. We have seen many patients in the last 5 months who are also very satisfied with the telemedicine experience. They're even grateful that they don't have to come inside another office where they might be exposed to COVID or other infections. It's not a one-size-fits-all. It is also usually easier to find a convenient time for both the patient and the doctor to fit into one of these visits. And some visits, we're calling it a visit, but it might be just a brief check-in over the telephone, or it might be a more computerized experience. One more technology that might just help you get your doctor's attention sooner is the patient portal. Almost every doctor now in the US is using some type of electronic record, and almost all of them have an option where you can send your doctor a secure message, sort of like an email, but it's protected by HIPAA, other privacy laws inside the doctor's medical record. If you mention in that message that you've been to the emergency room, you're very likely to get a faster and more timely response. I just want to take a moment here to mention, so we have both telemedicine and in-person options. Maryland State has made very strict guidelines about how doctors' offices could open up. In general, we have taken most of the chairs out of the waiting room to observe social distancing. Many places have put up plexiglass in front of their office staff when you come up to a registration desk. Of course, masks and appropriate protective equipment for doctors and nurses. So if you do need or prefer an in-office visit, we are also doing everything possible to keep you safe and prevent the spread of this disease. Now, one more. Okay. And as a primary care doctor, I'm used to providing care for all of my patients' needs. However, I work closely with our emergency room specialists and also many other specialists. And I mentioned earlier about longitudinal care, long-term relationships. I've been in my same practice for 26 years, and I have many patients who've been seeing me for 24, 25, 26 years. That's also very true oftentimes for our cardiologists, our orthopedists, many other specialists. And so how do you decide whether once you've been to the emergency room, you then contact your primary care or your other long-term specialist? Sometimes it comes down to who knows you better, who knows that particular problem better for you, and as well as sometimes how soon could you see either one. Certainly doesn't hurt to try to contact both your primary care physician and your specialist in the related area that you were just seen for. Okay. And lastly, a word about finding a doctor. It's not always easy, as you know. If you don't have a trusting long-term relationship with a doctor, oftentimes you may get a list, and Dr. Moses reminded me of this when we were preparing this talk. You may get a list from the hospital of doctors for that particular problem that you were seeing. That's certainly a very good place to start. It's probably also, though, a good idea, because those doctors are usually affiliated with the hospital that you were just at. So that's one measure of their safety and credibility. But it's still a good idea to talk to your friends, your family member, people who know you well. Oftentimes, if you do need to see a specialist, it's helpful to talk to that primary care doctor that you know well. But definitely asking around. Also, there are on websites for most hospitals and other health systems, some health insurances will have Find a Doc to be able to find a doctor in the area that you need. And those websites frequently have very helpful information, not just a doctor's specialty, it may be their bio, their training and background, even their areas of interest. I mean, some orthopedists may prefer to take care of your foot while others have a subspecialty in hand or shoulder or something else. And it's good to know that ahead of time. So one more thing that I wanted to mention was just about this idea of coming into the office or avoiding care. And just as Dr. Moses mentioned about appendicitis and strokes and heart attacks suddenly going down, unfortunately, another very difficult, unwanted effect of the COVID pandemic has been people not coming in for their usual care. Unfortunately, we've seen people with diabetes or asthma or other chronic conditions who were previously very well controlled and maybe would come to the doctor once every 3 months or once every 6 months to make sure they stayed safe with that chronic condition. And many of those people skipped their office appointments during the worst phase of the pandemic, and now those chronic conditions have deteriorated. We definitely don't want to see that. So whether it is in person safely or whether it is a telemedicine option, which we can also do safely, we absolutely want to keep seeing you for all of those chronic conditions to prevent them from getting worse, hopefully prevent the need to go to the emergency room in the first place. Again, the main purpose of today's talk has been to talk about the emergency room. So I just wanted to have a few minutes. I appreciate the time to be able to say a little bit about the before and after, and I'll be willing to take more in a question and answer period. But first, we're very privileged to hear a few words from Rabbi Rosenbaum, in particular about halachic aspects of emergency care. And
Thank you, Dr. Siegel. Appreciate it. Before we turn to Rabbi Rosenbaum, we may run a few minutes over the scheduled time for the program, so I understand those who have to leave, but hopefully we'll be able to answer a few questions and answers. So please start sending them my way, and I'll try to moderate them. Rabbi Rosenbaum, back to you now. Thank you.
Thank you very much, Max. And I just want to take the opportunity to thank both Dr. Moses and Dr. Siegel. We talk so much in this period about the gratitude we all have to medical first responders. So certainly to both of you for all you do in the community and beyond, but particularly to someone working in the emergency room day in, day out. We're as a community, we're very, very grateful. And thank you very much. And thank you for your presentations today. Of course, a big yasher koach to Max. I don't know if people see the participant numbers. I have right now 88 boxes on my computer being filled into Zoom. This, I believe, is the first program that Max has run by Zoom. So a big yasher koach to him and for taking the initiative to do this. Thank you very much. And if I could just give one more thank you, I don't know how we could have a Bikur Cholim event without thanking the man behind the woman behind Bikur Cholim, which is which is Neil Siegel. So many of you know Audrey Siegel well as really the tremendous force behind Bikur Cholim, to think of all the personal sacrifices that everyone in her family, and particularly her husband, have made over the years to help Audrey do everything she does for all of us. So we're certainly very grateful. Thank you very much. I really just want to take a few minutes to highlight some of the most common shilas that come my way regarding emergency room visits. First and foremost, as Max touched on, if heaven forbid something happens on Shabbos or Yom Tiv, may a person go to the hospital, may a person not go to the hospital? How may a person get to the hospital? So on a broad level, there are really three potential categories in halacha regarding a medical situation. One is pikuach nefesh. Pikuach nefesh is the possibility that something could lead directly or indirectly, I must emphasize, or indirectly, to a life and death situation. I think intuitively we grasp these types of things. Obviously childbirth, we're used to that's a childbirth, a labor situation is viewed as pikuach nefesh. Heaven forbid things that were dramatic accidents, dramatic falls, things that seem to be symptoms of potential stroke or heart attack, things like that. I'm sure there are many more, and perhaps the doctors could give a far more extensive list. But I think intuitively we get that something that is even possibly pikuach nefesh, whatever we need to do to get to the hospital and get it addressed as soon as possible, we should do. That might mean in certain cases calling our doctor to give us advice. My guess is if it's more of an urgent nature, that means calling 911. We should call 911 right away. If we're not sure, if we think it might be pikuach nefesh, but we don't know, it's a very important thing in halacha. Halacha greatly emphasizes that when in doubt, assume it is pikuach nefesh. So if you think it's something that you might be calling, maybe you should call an ambulance for, call first. If a person has a specific medical history and they think they're better off calling their doctor first, no problem, just do it. I can't tell you how many conversations I've had over the years, people telling me, well, they try to call with a shinui. So they're sitting there with their knuckle and a phone and they needed to call 5 times. That's a terrible idea. If it's a serious enough thing that, heaven forbid, a person thinks they might need to go to the hospital for an emergency, do it in the most effective way as quickly as possible. In a perfect world, if a person needed to do further malacha, further Shabbos or Yom Tov prohibited activity, they would have a non-Jew do it as opposed to themselves. But having said that, if a person feels they will be able to address the need quicker than asking a non-Jew to do it, they should just do it themselves. So if it wasn't, for whatever reason, if it didn't make sense to call an ambulance, but it was a pikuach nefesh situation, or even a possible pikuach nefesh situation, it would be theoretically better to use a cab or Uber, theoretically, but if one has the slightest doubt that they might not come quickly enough, a person should just get in the car and drive their family member to the hospital. I can't emphasize enough, if there's any question, do it, and don't try to be too strict. Now, there are other types of situations that are clearly not pikuach nefesh, but involve significant illness, significant pain, debilitating pain. Someone came to my door yesterday and they were advised by a doctor that it was possible they were having kidney stones, but they were also very clearly advised by a doctor that this was not a medical emergency, that obviously sometimes kidney stones could be a medical emergency, but they were clearly advised that it wasn't. It was an issue in dealing with extreme pain, and the question was, may they go to the hospital? The answer is they may go to the hospital. If there's no possibility of pikuach nefesh, then a Jew may not drive them to a hospital, but a non-Jew may be explicitly asked to do various things to get them to the hospital. That could mean knocking on a non-Jewish neighbor's door. There are still some people in Kent Mill who have non-Jewish neighbors. It could mean knocking on a non-Jewish neighbor's door and asking them to call. No hinting necessary. You can ask explicitly, and that could, whether it meant to call an ambulance, whether it meant to call a cab or an Uber, whether it meant to give them your phone and let them use the Uber app for you, all of that would be fine, and to ask explicitly would be fine. Now that's assuming, on the one hand, not pikuach nefesh, not life and death, or even possibly leading to life and death, but on the other hand, a significant debilitating pain or injury. If a person just didn't feel well and there doesn't seem to be any time urgency, then really one should wait until after Shabbos. By the way, an issue that came up different times with COVID and things of the sort, if heaven forbid a person is having symptoms of COVID, of course they should self-quarantine at that juncture. They shouldn't be out and about on the street on Shabbos. But unless they have other symptoms that indicate an emergency, that's not something one has to drop everything and start making phone calls for. That should be that after Shabbos, in other words, a person should contact whatever medical professional or go to the hospital, whatever they think makes sense. But if one intuitively understands it's not a medical emergency, then one shouldn't even be asking a non-Jew to do anything on their behalf, as long as it's not some type of possibly debilitating pain or something that might lead to something much more serious over the course of Shabbos. A related question that comes up a lot is a person goes to the hospital and the emergency room people say, you know, we've dealt with this, that, and the other, you could go back home. So may a person go back home on Shabbos or Yom Tov? So I think it's pretty fair to assume that if a person had a serious enough situation that they needed to go to the hospital, they could probably fall into that middle category that we mentioned before. It might not be life and death, but they are most probably a chola. They're probably not going to spend the rest of their Shabbos going on a walk. They're probably going to spend the rest of their Shabbos taking it easy in bed. And if that's the category that they fall under, it would be fine to ask a non-Jew to do malacha on their behalf, which would mean to ask the hospital staff if they could call a cab or an Uber for the person. And if they would be willing to, it would be fine to take a ride home. If a person has reason to believe that they might need to, sometimes people are in a certain situation before Shabbos and it's not serious yet, but it might get worse. If a person has reason to believe they might need to take a cab over Shabbos, it would make sense to set aside some cash in an envelope and stick it under a garbage can or something. And therefore it's there if a person needs to take a cab ride, and they could say, we don't handle money on Shabbos, but if you go under the garbage can over there, there's some money there for you. If a person didn't make that preparation, if they need to take some cash along, it's fine. In the hospital itself, obviously, we've already said that anything relating to life and death one could do or ask whatever is necessary. What about care for the patient in the hospital itself? Let's say the patient would like some more pain medication. Let's say the patient wants to contact the nurse. Let's say the patient wants the lights off so they can fall asleep better. So all of these cases, to the extent that they're a patient in the hospital, it will be reasonable to ask a non-Jew explicitly to do what's normally prohibited on Shabbos on their behalf, which would mean it would be fine to explicitly ask. Again, one doesn't have to ask a nurse, are you Jewish or not Jewish? We can assume that they're not Jewish. If they introduce themselves as Rebecca Cohn from the Bronx, maybe it's a different story, but assuming that medical professionals in the hospital are not Jewish, it would be fine to ask them explicitly to do anything having to do with the care of the patient, even if the general comfort of the patient, such as adjusting the bed, such as the lights. I want to mention another thing, which is probably maybe even more relevant in COVID, I don't know. If it's something that's of a rabbinic prohibition and it's for the sake of a sick person, one may do it on Shabbos with a shinui, with an abnormal way. So just to give a classic example, a person wants help. The nurse is not in the room, but there's a call button. But the call button is an electric call button. We wouldn't normally press a call button on Shabbos. If it has to do with care of the patient, I tell people who call me that they can press that call button with a shinui. A good shinui for a call button is, because it's really made to press with the finger. If you poke, let's say you have I'm holding a pen. I don't know if you have a pen around on Shabbos, but if you do, you could use it. If not, if there's a fork or something that was there on the table from your meal, you could poke the button with the fork or poke the button with something else. That's definitely a shinui, and that would be fine to call the nurse in that way. So when a person is ill in the hospital, they could either explicitly ask a non-Jew to do things on their behalf, or if it's an electric-oriented thing, they could do it themselves with a shinui, such as what we described. It makes no difference if it's the patient or the patient's loved one doing the act on their behalf. Two more really quick things. As someone visiting in the hospital, I get asked all the time, let's say not COVID, a person is able to visit in the hospital, what's the best way to get to the patient's room? I normally recommend to people not to take the steps. Even if someone will open the door for you, there's going to be all these problems once you get up to a higher, who knows what you're doing, you're setting off lights, this, that, taking the steps. I normally recommend to people visiting patients in the hospital to take the elevator. And it's a shvus to shvus b'makom mitzvah. I don't want to get into the details, but by the rationale, be shvus to shvus b'makom mitzvah, which would mean you could ask non-Jews explicitly to press the relevant button for you. To be clear, I normally wouldn't encourage people to take just a regular elevator on Shabbos, but in these circumstances, you could ask a person, you don't have to hint, hi, I need to go to the 3rd floor. Could you please press the relevant button for me? And that would be fine. To mention another shiloh that unfortunately is very relevant in these times, it's a case-by-case thing, but it's worth asking whoever you have shilohs to in the specific circumstances. If a loved one is in the hospital and you're not able to have other patients, other family members with the loved one in the hospital, is it acceptable to call over Shabbos and Yom Tov? Whether it be to call to get an update, whether it be to call to just speak to the loved one for a moment, that is a case-by-case shiloh, but it's a fair shiloh. And I would encourage you to ask it of whoever is your halachic decider if it's relevant. And then one more thing, this is not Shabbos or Yom Tov oriented, but it's general. Many of our hospitals, thank God, have kosher food. They're not a hospital under kosher certification, but they have kosher food options, which is wonderful. It is so important for the patient, if they're able, to double check everything when they get it. You must understand, the people who are bringing you the meals this is not their focus. So first of all, if it's a warmed up meal, you should make sure it came to you wrapped and sealed, because it was not warmed in a kosher oven. You should just make sure it came wrapped and sealed, which the vast majority of the time it is. You should make sure it's marked as a kosher meal, but what's an extremely common error is they bring you a fleischiks meal with milk. It's an extremely common error, and it's a very understandable error. So just when there are other things beyond what comes sealed, you should just make sure to watch it and look at it closely. I think that's all for now. Again, thank you very much for organizing the program. I think it's a wonderful service.
Are there any questions? Please send them my way. I have one question for Dr. Moses right now, and that is, you've hinted at it perhaps, but maybe be very explicit, things that people are concerned about. One of them is the signs of a stroke. How do you recognize it? If you could just give us a brief synopsis of those, that would be very helpful. Dr. Moses.
Okay, hi. So I think the big thing that people are familiar with regarding considering if they're having a stroke is one side of your body weak, one side of your body numb. Some things that are less well understood would be if you're dizzy and feeling off balance with your walking, or vision changes can be signs of a stroke. Just because, let's say half of your body became numb and weak, but then it lasted about 2 minutes and went away, that is also an emergency. That is what we call a transient ischemic attack, or a mini stroke is how a lot of people think about it. And it's sort of like the warning bell that a stroke is coming. So that is not something to sit around. You're not going to be the one who's rushing off to the fancy big intervention procedure if you don't currently have those symptoms, but there definitely is a big workup required at that time to make sure that we can't alter an impending stroke that might be coming. So those are the big things that I think about. Somebody else asked me individually on the chat, if Max, is it okay if I?
Yeah, go right ahead.
Okay, so somebody had asked about, how the neighborhood hospitals and coronavirus care, and how, if they're all good and things like that. So I think that I really can't speak to what all the hospitals are like, because I only work at Holy Cross and Holy Cross Germantown. But what I do know is that wherever you were in April or March, the care is probably better now than it was then, because we all learned a lot. And I know that it took a lot more head scratching and figuring out in March and April to decide what to do to help patients get better from coronavirus, even in the acute setting. And our intensivists and our hospital doctors and our respiratory therapists, everybody has really learned an intense amount. Holy Cross does a very good job with that, but there are some times when really severe interventions are necessary, really extreme things, and those extreme things like putting somebody on a like sort of heart-lung bypass and things like that, those are only done at tertiary care centers like University of Maryland or Johns Hopkins or the big hospitals in DC. So most people do not go from zero to requiring those interventions. So presenting to a hospital like Holy Cross in times of coronavirus is not at all a bad idea. We have a lot of experience in getting people stabilized, and if further more extreme measures are necessary, we also have a lot of experience transferring patients where they need to go.
That's good that you mentioned COVID, Dr. Moses, because we have a question that sort of follows up on your point, and either you, Dr. Siegel, can take it, or both of you. Here's the question: if your doctor treats COVID, can he or she be part of the team or have access to speak into the emergency room team? Also, if a doctor has knowledge of specific conditions that you have, can they be contacted or called in? Dr. Siegel, you want to start us off, please?
I think I'll try to answer the second question. I'm not sure that I totally understand the first. So ahead of time, if a doctor has very specific knowledge of your conditions, I think that is going to depend on how severe your immediate condition is in the emergency room and how much the emergency physician needs to do, and how busy they may be. I think that the emergency physicians are so well trained to treat you in the moment that they're going to work on that first. Of course, we'll ask Dr. Moses to speak to that. But as far as contacting your doctor while you're in the emergency room, it's going to depend. One thing I meant to mention in my talk, in the state of Maryland, we do have a very excellent system for after the fact. There's a statewide electronic register for all hospitals for patients who've been admitted to the hospital or even just seen in the emergency room. And every doctor with an electronic record has access to that. So when Dr. Moses sees you at Holy Cross on Sunday, if you come to my office on Tuesday, I can already see the tests that she ordered, the results. I can see any CAT scans. I can see oftentimes the doctor's note. So certainly well worthwhile that way. I don't know, Eva, if you want to speak more to when an emergency doctor would or wouldn't call the primary doctor or specialist.
Sure. So regarding if your doctor treats COVID, can he be part of the team or have access to speaking to the ER team? I think, if this is a primary care provider, most likely they are going to say, if it's beyond, what they do at home, they are going to they can definitely call and check in, and you can request that the ER doctors call and check in. That may, depending on time availability, but I don't know, Dr. Siegel could tell me if I'm right, but I can't imagine there would be too many of them who would have many opinions beyond what we do in the ER when it gets worse, because there's not a lot that they can do to support you at home when it's getting bad, and they're probably going to say whatever the ER says at that moment. Would you agree with that, Dr. Siegel?
Yeah, thank you. I think that's true. Another thing, I'm sure you've heard a lot in the news about every medical setting, emergency rooms, hospitals, physicians' offices are being very careful still to conserve the PPE, the protective equipment. And many primary care doctors, therefore, have chosen not to even see patients with possible COVID in their office. For those who do, and usually affiliated with larger health systems, they're still taking great precautions. And so we screen patients before they would come to the office. I guess there's three categories of people who may have COVID. There's people who have either no symptoms or very mild symptoms, and then they don't need to come either to the office or the emergency room. There's patients who have more significant symptoms, real distress, and of course, those are people who should be going to the emergency room. Might be in between. If you have, a cough, a little short of breath, not sure if you need to be seen, it needs to be at a place where the medical team can do the protective equipment. So you'd have to check with your doctor's office ahead of time if they're prepared for that. If they are, you may be able to save the trip to the emergency room that way. If the office is not prepared, they may be recommending that you go to the emergency room.
Yeah, and one example, and it's just because it's a large system that I interface with a lot, is Kaiser. They particularly have protocols where if a patient is diagnosed with COVID, which they swab for in their, I don't know if it's in their urgent cares or in their primary offices, but they do swab for COVID at Kaiser. I know because the people will tell me they got swabbed and diagnosed at Kaiser. Then they actually have a daily telehealth check-in with their patients. So because, and maybe they have a home pulse oximeter, but also a lot about the pulse oximetry is tricky to interpret at home. So that's another little plug I have is if you feel great, but your pulse ox says your oxygen saturation is in the 70s, then it's not picking up right. So your fingers are cold or something, because, more we go based outside the ER on how you feel and whether you can stand up and walk across the room without breathing heavily, that sort of thing. Those are much better ways, although there's always exceptions. Regarding speaking to your doctor, doctors will frequently call the emergency department and tell us that they're sending someone in and tell us what their concern is about why they're sending the patient in. And then at times they'll give us a phone number and want us to call back. At other times they'll say, I know that they need X, Y, Z, just do it and you don't have to take the time to call me back later. Other times when I really do make a strong effort to call a patient back is if they're sort of the in-between. They don't need to be admitted to the hospital, but I also don't feel that they have a great handle on what's going on. And I'm really worried that if they don't get reached out to by their doctor, things are going to fall through the cracks. And in those times, or I think that perhaps there might be something that the patient doesn't recognize is the main factor. Let's say I personally have seen them 3 times and each time they're having anxiety, but they feel it is something else. And I can't, we've done a big workup 3 times. And now at this point, I really do think it would be helpful for the primary doctor to talk to them about it in a less charged setting. So in those times, I will make a very strong effort. Sometimes even if I saw the patient at 2 a.m. and I don't feel that the doctor needs to be awoken at 2 a.m., I'll try to make a note for myself to call at 9 in the morning. So those are the times when we really kind of go beyond and really, really try very hard to reach out. But doctors call the ER frequently and they always get to speak with somebody at some point. Sometimes they may have to hold or wait if we're in the middle of something more emergent.
Okay, thank you very much. A couple of observations were made. One is that one way you can prepare yourself is to have the copies of your relevant insurance and ID with you on your phone. Make an electronic copy of it. That way you can have it easily available, because that just simplifies what documents you have to have on your person. Another comment which somebody would have to provide additional information is, in addition to the kosher meals that hospitals have, it's worth mentioning the Bikur Chalim has additional provisions at most hospitals. I don't know if that refers to food, but certainly they have emergency boxes, and I made mention of that at the outset. There are no other questions that I'm aware of right now, so I want to thank very much both our doctors and of course our Rabbi Rosenbaum for taking the time for continuing to do what they do to keep us safe and to make their knowledge available to us. We are very fortunate to have a community when we can tap people of that caliber to inform us, educate us, and help us get through this process and through these times. So we also welcome your ideas for other programs that will be helpful to share with the rest of the community. We'll be looking forward for your input, your ideas, how we can improve and can help each other. Thank you again for all your help. And if there are other questions, please send them my way and I'll try to get the answers for them as possible. And I will also try to have the recording of this program on the links either Bikur Chalim or other places as soon as possible. Thanks again. Have a great day. Wishing you a great Chodesh and a great week. Thank you for your time.
Thank you.
Thank you.